It's 1 minute past, so we can just get started. So good evening, everyone. Thank you for joining us, and welcome to our third Sunday supper sessions. This evening, we've got some excellent talks on the elbow. Before I get started, just some quick housekeeping. So there'll be some feedback sent out at the end. If you could all fill it out, it really helps us to continue these sessions running and to sort of tailor things to our attendees. We've also got some announcements to make. So BOTA are just about to launch our traveling fellowship grants this year. So we've got several of grants available at varying levels for people who are going on fellowships in the next year. And there'll be some more information if you follow that QR code, and we'll pop it up again at the end. And Ollie, who's our treasurer, can give you some more information about that. We've also got some announcements coming soon regarding our virtual congress, which will be running later this year. So keep an eye on your emails for more information. And our new Fellowship Finder website, which is now live. So it's just Google Fellowship Finder, and there's loads of information on that website about potential fellowships, real life reviews, including sort of operating numbers and information. It's great for those of you who are looking for that. So without further ado, I'll hand you over to our first committee member, who's going to introduce our first speaker.
Good evening, everyone. BOTA has the pleasure of welcoming three eminent speakers. First, we have Mr. Livio Di Mascio, who is a consultant trauma and orthopaedic surgeon at the Royal London. He is heavily involved with higher surgical training and is a popular trainer in his region. So I'll hand over to Mr. Livio Di Mascio.
Thanks, Crilly, and thanks, George. Thanks for inviting me. Where are we? Okay, so share screen. How's that? Does that work? Okay, welcome. Distal humerus fractures. I can't actually specifically remember what the title was, but basically this is a simple talk really pointing out some fundamentals that you need to use to actually come out with a good outcome and avoid complications. Those of you from around the country, the Royal London is one of 4 MTCs in London. There are now 2 helipads in London. There's one at St George's and one at the Royal London, which has been there for 25 years. And these are the Teletubbies that come and collect some injured patients and bring them back to our hospital. This doesn't reflect the last year, but ordinarily there's been like 9.3 million people within a mile of our hospital, which actually makes the treatment of orthopaedic injuries quite challenging, because those people that ordinarily would not survive are beginning to survive and give us hours and hours of fun, as it were, in the operating theatre. So talking about distal humerus, the elbow, we're all talking about the elbow this evening, and I'm sure all of us have got a similar slide. The elbow is unfortunately prone to stiffness, and elbow stiffness is a real problem for the patient. So normal range is from 0 to about 140 degrees, and there's about a 90 degrees range of pronation-supination. What the patient needs functionally is more flexion than extension. So the functional range is from about 30 to 130, or even 45 to 130. The 130 is key, because what your elbow does, unlike your shoulder creates a sphere of space to put your hand into, and your elbow actually achieves that range within that sphere. And you need to be able to get your hand to your mouth, which is tremendously important. And the 2 things that patients complain about are inability to feed themselves and inability to self-care with things like brushing their hair or brushing their teeth. So the distal humerus anatomy is really made up of 2 pillars and a bow that crosses and supports those 2 pillars. There is compression forces down these pillars. And these will reflect the pattern of injuries that we will see in fractures. In the sagittal plane, the center of rotation is at the anterior humeral line, and therefore there is tension over the posterior aspect of the humerus and compression forces over the anterior aspect of the humerus. And again, these will reflect injuries that we will see. So Rensburg Radin came out with this classification. It's very simple, and truth be told, for your exam, it's nice to know a classification, but truth be told, none of them are particularly helpful, as it were, in deciding how you're going to treat it, because most distal humeral fractures that are intra-articular or even supracondylar fractures in an adult are going to require operative fixation. And the classification does not necessarily tell you how you go about that. Here's yet another classification, lambda view, supracondylar, low, high, increased complexity actually of the fracture, if it's distal, will perhaps dictate how you approach it surgically, but not necessarily how you fix it surgically. The AO classification is quite helpful because it actually does include this sagittal plane injury, this B3 injury, of which there are a number of variants, but it's really the only classification that has highlighted the fact that there can be a sagittal plane injury. So complete articular fractures, well, these are really the ones I'm going to talk to you about. These are perhaps slightly trickier ones, and the lower the fracture and the more fragments that involve the trochlea and the capitellum mean that it's going to be slightly more challenging to fix it. So what I want to do, and these are not my ideas, these are really ideas that have been around for many years and really coined by O'Driscoll, but what we want to do is apply some principles that will not lead to something like this. So this has failed because there has been failure of stability and there's been failure of compression. It's not because, first generation plates have been used, but unfortunately it's just that certain principles haven't been followed, and therefore this has gone on to a non-union. This is, I put this up, this was sent to me by a friend a couple of years ago. And again, failure of principles of treatment have led to what is a catastrophic failure of the fixation. So, surgical approach. Let me get rid of, oh crikey, clear all. Surgical approach. There are a number of surgical approaches. I know Lee's very keen on the Boyd approach. It is an elegant approach, and it will give you access to most of the distal humerus. Paratricipital approach, well, that's really an extension of the Boyd, but medially, the advantage of all of these approaches is that you keep triceps on and they aid your rehab. But there is absolutely, in my opinion, very little wrong with doing olecranon osteotomy if you can't achieve what you want to. And what we want to do is achieve anatomical stable reduction and reduction of the anatomical surface of the joint. So you can start off with a Boyd, and if the fracture is a bit fruity, then there's no harm in doing an osteotomy. So what are these principles, these magical principles I'm telling you about? What you want to do is maximize fixation in distal fragments, and all fixation in the distal fragments should contribute to supracondylar stability. So if you've got those two things in your mind, then actually you'll go a long way. So this is an Italian arch, and this is very similar to what the distal humerus looks like when you've got the patient supine and looking at you, and what you want to do is reconstruct that trochlea capitellar complex between those two pillars. So how do we go about that? So as I said, O'Driscoll came out with a sort of like a seminal paper really describing his technique on how you achieve this. So all the screws in the distal fragment should pass through the plate, should be anchored in a fragment, and there should be as many screws as possible in the distal portion of the fracture, and they should be as long as possible, and they should engage as many fragments as possible, and they should interdigitate, interlink, and that actually increases stability. So the reality of that, well, what does that mean? Well, if you've got a screw in the distal portion of your fracture, it should engage the far pillar. Similar, it passes through any central free-floating fragments, And then if you get at least 2 long screws that engage the far pillar, they will interdigitate with that central fragment and support the trochlea. So how do we do that in reality? With patients supine, maybe with a sandbag under their shoulder to help with the humeral positioning for you as the operative surgeon. Usually you're on the ipsilateral side of the injury. What you want to do is create your reduction, and to do that I use 1.6 millimeter K-wires, and the temptation is to fix the distal block and then reduce the block onto the shaft of the humerus. I must say I tend not to do that because it tends to, I mean, there are no absolute rules, but it tends to overcomplicate matters. So much the same way if you have a distal femur or a pilon or something like that, what you want to do is fix a fragment back to the constant fragment, which is the shaft of the humerus. So I would start either on the lateral or medial side, depending on the fracture configuration, when I can identify whether there is a strong cortical read either here on the lateral side or the medial side. So if I start on the lateral side, then I will start with this pillar and then go to the articular fragment and then end up on the medial side, or vice versa. Then you place your plates on. Honestly, it doesn't really matter what plates you use, and then there is the discussion of whether you use 180-degree plating or 90-degree plating. In this instance, 180-degree plating is used. And then if you position your plates on the distal humerus and then use a 2 millimeter K-wire, so most of the humeral systems will have 2.7 millimeter screw, locking screw, that goes over a 2 millimeter drill hole. So to avoid you clashing with drill bits and ending up with drill bits that break in your distal fragment, what I would suggest you do is you use a 2 millimeter K-wire, which is not threaded, and then you position where you believe you're going to put your screw. Put your plate on using a sliding screw and don't tighten it, and try and use the proximal end of the distal end of the sliding screw with your drill hole so that you can achieve compression later. So once you've got your plates on and your wires in, then swap out your 2 millimeter wire for a 2.7 millimeter screw. It's the same with the Acumen system, or the Synthes J&J system. And then lock your screws in the distal fragment. And once you've got at least 2 distal screws, then this is really important. This is a step that is often missed out. You want to achieve compression of that supracondylar reed that you achieve your reduction with the K-wire. So you put a clamp across it and you put it through the opposite screw that is sticking out and achieve compression, and then tighten your sliding screw hole, and then do the same on the contralateral side. And by doing that, you achieve supracondylar compression, which is an important part of humeral fixation. The argument of whether you use parallel plating or 90-90 plating, truth be told, I don't think it really matters. Here is a paper, biomechanical paper, that suggests that they're very similar, but there may be better torsional resistance in the 90-90 group. But I could quote other papers that say the complete opposite, in that they are similar, but perhaps 180-degree plating is better. So parallel plating, however, does have a limitation in my hands, and that is when there is this coronal shear element, when there is a very distal fracture where the capitellum or the trochlea come off the front of the humerus. And in that setting, unfortunately, this capitellar fragment does not necessarily get much fixation, if any, from your plate. And I want to get fixation that is contributing to supracondylar stability, which means putting headless screws in alone is not necessarily going to be beneficial for the patient. So to achieve that, actually, Diffuse Synthes, there are a couple of other companies that do plates that are combination plates, posterolateral plate, but with an outrigger that allows you to put 180-degree fixation as well as coronal plane and sagittal plane screws in at the same time. So a couple of examples. Let me just check what we're doing with time. So we've got time for a couple of examples. 29-year-old girl fell off a bike, closed isolated C3 fracture. This is a very low H-type fracture. So what that means is that there is a medial epicondyle, a separate trochlear fragment, another trochlear fragment with the capitellum. And applying those principles, what I've done, I've used, because it was low, this posterolateral plate with the outrigger. So I've got my long screws that interdigitate across that H free-floating trochlear fragment. I have done an osteotomy. It was a low fracture, and I've got no bones about that at all. But the important thing is that actually, if you get anatomical reduction and restore this center rotation in front of the humerus.
This is at 4 months following intercondylar fracture of distal humerus. So you can flex up for me. Fabulous.
So they never go absolutely straight. They lose about 10 degrees of flexion.
You do exactly the same.
I mean, extension.
Side, so extend. Okay, flexion. Fabulous, and then fabulous.
And you could see her X-ray in the background. I've sort of started doing that with her clinical videos, just because you could take a video of anybody actually. And so she had a nasty fracture, and actually very early on, she got her range back. Other things that are important, not of just the surgery, there are things, edema control. I tend to give people non-steroidals because I achieve that compression. I'm less worried about non-union. And I tend to give people a single shot of high-dose steroids actually at the time of surgery. Often the anaesthetist does it anyway as an antiemetic, but I think it significantly helps post-operative edema, which is an enemy of range of motion. Another example. This is another H-type fracture. So how do you do it? I did an osteotomy. It was low. I put my wires in. He had a radial head fracture as well. And then using 2mm wires, you can see medially and laterally, this is the ulnar nerve. I've got the screw in the sliding hole, and then I achieve compression. The nice thing about the posterolateral plate is it makes sure that you achieve your sagittal plane correction. So this is before I've actually tightened up any of the screws. And then once you tighten up the screws, you get that sagittal correction back, which is the thing that is going to give the patient their deep flexion. And then there you go, achieving compression with the clamp, tighten your screws, and then hey presto, anatomical reduction at the end. And yes, I've done an osteotomy. I've got no bones about that. Here's an example of somebody, this wasn't one of my cases, one of my colleagues, and I found it out not because I was sort of like relishing the fact that something had gone wrong, as it were, but I thought this was a brilliant example of the fact that you'd done a beautiful operation, but the one thing that hadn't happened was supracondylar compression was not achieved. You could actually see it in the IIs and in the post-op period. Patient got their range of motion back, but actually what happened with time was the plates fatigued. They did go on to unite, sort of like they dynamized. But they dynamized into extension, and unfortunately, because their sagittal plane correction is no longer there you go, they've lost their range of motion. So they've got an excellent range of motion, but they're unable, they're not super happy because they can't, brush their hair, as it were. Nearly done. The capitellum's right under the skin here. Again, you can't fix that with 180-degree plating. And sometimes the fragments are so small that you can't put screws in them. So actually putting some wires in and cutting off the wires or using some headless screws, it is not a bad thing to do for the patient. And actually, again, same lady, probably about 5 months after her surgery.
Okay, and then
on the right
again.
side, this is.
And then palms to the
So
floor.
Again, she hasn't got
Fabulous.
fully straight. But given a pretty shitty injury, she's actually done extremely well. Anyway, I think we're sort of done. Oh, this is a fruity fracture. This is a terrible triad with a distal humerus fracture. Anyway, again, osteotomy. Not that I do osteotomies in everybody, but it does actually help you when you've got to restore your joint.
You're a boxer, huh?
Yeah, I used to be.
Okay, straight again, and then twist your wrist. Okay, and then 1 second.
So didn't do so bad. Unfortunately, his legs aren't going so well. But anyway, so a combined plate is sort of invaluable. That sort of posterolateral plate with an outrigger is very useful when there's a sagittal plane problem as well as coronal shear. Think about your sagittal reduction. You want to actually get your central rotation in front of the anterior humeral line, and that actually is the thing that will help achieve that flexion for the patient. And I think I'm to time. So any questions, guys?
So the one question we have from a trainee is, do you use bone graft for the fractures?
Occasionally. So if it's an open fracture, no. I would restore the anatomy and then come back at an interval time to maybe sort of 3 months to bone graft it. Occasionally, depending on how much bone loss there is, I will shorten the humerus. So effectively what you do is you bring the humerus down into the olecranon fossa, and then you plate it, and then you need to recreate the olecranon fossa, coronoid fossa. You get a burr out, and you basically burr a hole in the distal humerus in the shaft. But occasionally I will bone graft acutely, but usually it's sort of not necessary.
Okay, I think question, we've got time for only one question. How often do you have to remove metalwork in these patients?
So if I do, truth be told, you put, I don't, unless the patient comes back. If they have a plate on the olecranon, sometimes they decide to have that out in the future. Removal of metalwork as a routine just sort of isn't a thing that I do. And if you're removing metalwork, I will do it if I'm doing an elbow release, if they've become stiff. So I will take their hardware out at that time, just in case they get a hematoma and an infection.
Okay, thank you very much, Mr. Livio Di Mascio. So next we have Mr. Lee Van Rensburg. He is a consultant trauma and orthopaedic surgeon at Cambridge University Hospital, dealing with high volume of complex elbow trauma. He's a regular faculty member of both national and international courses, and is another popular trainer. And having had the pleasure to be one of his trainees myself, I can totally see why. Over to you, Mr. Van Rensburg.
Thank you, Romina. I'm going to talk about there are triads and then there are triads. What are my objectives? And the objectives of this talk really is just to get you through the FRCS. There is some clinical stuff, but mostly this is about the exams. And you're welcome to join us on Thursdays and Fridays if you just go by cambridgeorthopaedics.com. In terms of instability, there's a spectrum of instability from simple dislocations to complex dislocations. And with complex instability, there are the severe soft tissue injuries, the terrible triad, the anteromedial coronoid fracture, or the posteromedial rotatory instabilities, and then the proximal ulnar fracture dislocations. And what I'm going to be talking about today is the small subgroup of complex instability, the terrible triad. The anatomy you need to know is the medial side, the ulnar collateral ligament with the anterior band, the posterior band, and the transverse band. And on the lateral side, we've got the lateral collateral ligament proper inserting into the annular ligament, and then this complex structure, the lateral ulnar collateral ligament, essentially a tether between the ulnar and the capitellum, or the lateral aspect of the capitellum. The terrible triad is an elbow dislocation, coronoid fracture, and the radial head fracture. And Ring, elegantly in his paper of 2002, told us how troublesome and unpredictable this is, and how after you fixed everything, including the coronoid, the collateral ligaments, and possibly the MCL, be prepared for persistent instability. Here's a 47-year-old lady who sustains a complex dislocation of her elbow, gets beautifully reduced and put in a back slab, and there she is, day 2, dislocated again. She goes back to theatre, has an MUA day 5, gets put into another back slab, and surprise, surprise, day 14, she dislocates again. Goes back to theatre, has a radial head replacement, and gets put into a back slab. And then it gets picked up, sadly, 6 weeks post-injury that she's dislocated in her cast. They put her in a better cast, and she's still dislocated. She finally ends up with a dynamic X-fix and gets an arc of movement of around 65 degrees, and by 8 weeks has got no lateral compartment left in her elbow. And that's why the terrible triad is called the terrible triad. Because if you don't treat it properly from the start, it truly is a terrible triad. So this was Ring's paper, 2002, 11 cases, showing us these scary pictures of how bad the terrible triad can be. Of note, all were reduced and put in a splint, 7 redislocated. 10 had surgery. Of those, 5 redislocated in their splint. And they say at the end that the treatment of these troublesome injuries is to restore elbow stability. Well, that's why you set out to do it. I think what they should have really spelt out was that in complex instability, you can never excise the radial head. You have to fix it or you have to replace it, but you can't excise it. And the last thing that I really take from this paper is that back slabs and splints don't stabilize elbows. All 7 dislocated, 5 post-op dislocated. And we saw that in the case that I showed. And you really need to buy into this idea of static incongruity and dynamic congruency. The drop sign, the distraction between the ulnar humeral joint, which you sometimes see on an X-ray, highlighted beautifully by this paper, showing how as you transect the ligaments around the elbow, the distraction increases. And in fact, if you add weight to that elbow, even in the form of a brace, you will increase your distraction by 2 millimeters. And so adding weight in the form of a back slab or cast is not a good thing. I love what Duckworth writes, and him and McKee wrote this paper in 2008 and showed us how with active exercises, you reduce the elbow. If you fire up brachialis, it pulls and reduces your ulnar humeral joint. If you fire up biceps, either just by direct flexion or by active supination, it pulls on your bicipital tuberosity. It reduces your radiocapitellar joint. If you actively pronate a forearm or passively pronate a forearm, it winds the biceps tendon around the bicipital tuberosity, once again, reducing your radiocapitellar joint. The only 2 movements that are bad are passive supination. So if you passively supinate a forearm, you can generate PLRI and you can push that radial head off the back of the capitellum. And the other movement is shoulder abduction, because if I abduct my shoulder, I put a varus force across my elbow, stressing that lateral ligamentous repair. You need to be sure that your elbow is stable enough to get moving. And this has been described as the hanging arm sign. And for the last 15 years or so, for me, it's whether that elbow is stable and congruent to within the last 30 degrees of extension. And so I'll screen them under II. And most elbows are stable in flexion, but they start to become unstable as they go into extension. And I want to see on my X-ray that that elbow is nice and stable to within 30 degrees of extension. This is how I EUAO an elbow. I bring the II parallel with the bed. I flex the elbow 30 degrees to unlock the olecranon, put my varus force, assess what sort of lateral injury I've got. I then put a valgus force on it, and this is an intact elbow, and it looks like he's generating valgus. But what you want to do is pronate the forearm. It locks the shoulder in place, and in people who are having PLRI, it will lock the radial head onto the capitellum, showing us pure valgus instability of the medial structures, MCL and CFO. I know I'm going quickly, but there's a lot to get through. And the great news is this will be repeated and you can get a copy on the website. I then bring the image intensifier around for the lateral. And now I'm screening on the lateral view as I go into extension and checking how stable that elbow is. And if I get that kind of X-ray, a perfectly reduced radiocapitellar joint, a perfectly reduced ulnar humeral joint, I know that elbow's stable. And if I'm really feeling confident, I might go on to the hanging arm sign. So the first principle of the treatment of elbow instability is turn a complex dislocation into a simple dislocation, and don't forget the last step. The last step is get it moving, because movement makes an unstable elbow stable. And how do you know if it's stable enough to get moving? Well, you can do the hanging arm sign or screen it to make sure that it's stable to within 30 degrees of extension. With the terrible triad, we have to deal with the radial head, the coronoid fracture, and the dislocation. And there's a lot of protocols out there. This one comes from 2011 that talks about first fixing the coronoid, because once you've fixed everything else, it's very difficult to go back to that coronoid. They then fix or replace the radial head, repair the lateral structures, and reassess the stability. And then only go around the medial side if you need. Why? Around the medial side is the ulnar nerve. And if you go around the ulnar nerve and mess with the ulnar nerve, you will generate mischief. It's much more difficult to get the medial collateral ligament repair absolutely isometric. It's actually quite easy to do the lateral sided structures. And often, once you've done everything on the lateral side, you don't have to go around target territory on the medial side. I'm going to start with the coronoid because that's what they suggested fixing first. And then you see this paper, 2014, suggesting that the coronoid doesn't need to be fixed. No, man, I don't quite understand. Do I fix the coronoid? Don't I fix the coronoid? They talked about Reagan-Murray 1 and 2s in select cases, unnecessary surgical fixation, actually going that far to say that not fixing the coronoid may positively affect functional outcomes. I really think they were pushing it a little bit too far there. These are the pictures they show us. Complex instability with a relatively small coronoid fracture, treated, seems to have done okay. Now, when you think of the coronoid classifications, we've got Reagan-Murray, O'Driscoll's from the 2000s, and then this current concepts of the Wrightington classification showing us that bifacet coronoid, the one that's hiding in there. That's why they're triads with capital letters, and there's the triads with small letters. I don't think you should rely on the Reagan-Murray. Forget about it, really. It gave us an idea back in the 80s, but you really need to think of your coronoid in a three-dimensional structure, and that's where O'Driscoll's classification, although a little complex, is worth remembering. The Watts classification or the Wrightington classification that came in showed us how you can have a terrible triad, a dislocation, with a bifacet coronoid, the Bs, as opposed to the standard one. And watch out for them, because some of those terrible triads with capital Ts are lurking, and you don't see them until you've had 50 or 60 of them come past your doorstep. Now, most terrible triads are this small little piece of the intermediate ridge. Sean O'Driscoll called it the tip. I think we've moved on from that. It's the intermediate ridge. It's that little piece. That's the piece that's associated with your PLRI kind of terrible triad. So there's a dichotomy here, isn't there? Between Ring of 2002 telling us that even if I fixed everything in the coronoid, I still might have instability. And this group from 2014 suggesting, maybe you don't need to do the coronoid. And that's when you need to realize there are terrible triads, 3 men from the East who are a little bit deadly. And then there are 3 notes played on a piano, which is actually quite beautiful to listen to. So here we see a 74-year-old lady who has a fractured dislocation, complex instability, very small piece of a radial head, very small coronoid, post-reduction films beautifully reduced radiocapitellar joint, no drop sign, even in her back slab. And I'm just going to play the sagittals, focus on the sagittal images. We see the radiocapitellar joint is beautifully reduced. We see that the ulnar-humeral joint is beautifully reduced. In the static incongruity pattern, we've got a tiny little piece off the top of the coronoid. And if you have a look on the coronal views, you'll see that that would be in the region of that intermediate ridge. It's not a bifacet. It is not a anteromedial coronoid. If I play those sagittals again, you'll find that that radial head fragment is a very small piece and it's not in the joint. And so not going to block this radial head in any way. And so she gets treated non-operatively. You could probably say the brace was a little bit of overkill, but there she is at 3 months with a reasonably good looking x-ray. 2010, they told us about this case series from Ring, non-operatively treated terrible triads, but there's a few provisos here, much like that case I've just shown you. Selected cases, small fragments, well aligned, no mechanically blocked, minimally displaced, and in big letters, might. This is a case series of 4. We don't really know the natural history of these yet. I think you can treat terrible triads non-operatively with these provisos, but I do think you need to watch them like a hawk. Bring them back at a week and x-ray them. Don't leave it like that first case 6 weeks before you know that that elbow is dislocated, because then you will really be in the world and remember what terrible triads really are. Here we see a 45-year-old with an open fracture dislocation, so complex elbow instability. There's a radial head fracture and a coronoid fracture, so technically this is a terrible triad. You can see the gas from the open, but let's just ignore the open component for now. Fairly big radial head fragments, which may jam this head. Not a congruent reduced ulnar-humeral joint. You can see it there, can't you? That sort of how this forearm is falling away, the drop sign. But it's not just dropping straight down, it's also rotating round. You see that on the 3D CT, the series number 2, how it's sort of subluxing, that posterior medial rotation stability. And when we get our final cuts, we see, is this possibly a basal coronoid? The Wrightington-Watts classification of B hiding in here. Problem now is he tells me to fix the coronoid, but this coronoid is fairly comminuted and fairly small. And if I have a look at my sagittal, it's not just about the height, but look at the width of that coronoid. There's probably 2 threads worth of screw that I can put into that coronoid. Can I buttress that with a buttress plate? I don't know, man, I don't know. There he is as a weak subluxed elbow. This is about to dislocate soon, so you need to fix it. So we follow the protocol. I normally don't, when I say I fix the coronoid, I'm not really fixing the coronoid, but I'll always fix that anterior capsule, because that anterior capsule is also the anterior insertion of the annular ligament. But here the radial head has been fixed and the lateral collateral ligaments repaired. And we see to the varus stress, it's nice and stable now. To valgus stress opens up on the medial side more than a 5, 6, 7 millimeters. And so I know MCL and common flexor origin has been injured on the medial side. But the presence of valgus instability does not mean that I now need to repair it. What I need to do is find out if this elbow is stable to get moving. And I know that if it's stable and congruent to within 30 degrees of extension, which is what it is. But I get him back day 4 because running through that, there's a little bit of a drop sign in the middle. And I'm a little bit nervous about this one. And I'm always thinking, should I have gone around the medial side? So I bring him back early. I'll bring him back day 4. And I see how we've got that drop sign. And I'm worried here. So I listen to what Duckworth says. And he says, look, if you fire up brachialis, biceps, and avoid varus stress, the tone will pull that elbow back into place. And so I wait a week and I chase him with more exercises. And I rehab him supine. But what I don't do is I don't put him in a back slab. And what I don't do is put him in a brace. Because I know that if I put him in a back slab or put him in a brace, it's going to add weight and increase that distraction. And then he will dislocate. But in fact, by day 11, he's no better. And I can't leave a 45-year-old point loading on that corner of the trochlea with their coronoid. And so he goes back to theatre and has the MCL repaired and the coronoid fixed with a screw and 2 or 3 threads into it. It was a reasonable size. And after doing that, that elbow is stable and congruent within 30 degrees of extension. And here we see it at 3 months, stable and congruent, no longer point loading, a little bit of an HO around. What about the radial head? Well, I don't have time to talk you through all the approaches, so the video's out there on Cambridge Orthopaedics YouTube channel. But what you need to think about is, am I going to fix it? Am I going to replace it? But what you can't do is excise the radial head in complex instability. Rule number 1, no debate. When do you fix? When do you replace? Complex discussion. Generally, if you see 2 pieces, that means there's 3. And if you see 3, there's 4. Generally, if there's 3, that means you can fix it. And it is acceptable in young patients to assemble it on the back table and use it as a fresh osteochondral autograft. Ring, as he said, as time went by, he became more likely to replace. And when he replaced it, made sure he didn't overstuff it. There are lots of ways of fixing it. Up until a few years ago, most of us were fixing these complex radial heads with plates, but they can sometimes lock your pronation and supination. I don't want to rehash that debate where Roger Van Rick beat me. Essentially, he was debating in favor of screws or plates. The difference is 18 degrees, but I can say as a wind, gradually with elbow surgeons, more and more we're going for intramedullary fixation, but we still have to define that. It's still relatively early days. So fix it with a plate or screws and having a good argument why you may use one or the other. Thank you, George. If you do fix it, you don't want to overstuff it. You want to make sure that you see that point. It's not proud of the lateral facet for the ulnar-humeral joint. Which radial head? Nobody knows. When it comes to the dislocation part, you've got the lateral ulnar collateral ligament. You need to think of that as a Y. If you break it in one place, you get laxity. You break it in two places, you get instability. It normally gets pulled off that lateral epicondyle, and the acute repair is actually fairly easy with an anchor dead center in the capitellum. Make it a decent sized anchor with decent sized sutures. You don't want to be able to tiny sutures. You want to get this elbow moving right from the beginning. Have the concept of the internal brace in your head. If they do shred mid-substance, where do you put the anchor? Well, you put it dead center into the supinator crest. It doesn't really matter if it's proximal or distal. Last points I'd like to make. Here we see varus and valgus instability, unstable in extension. Lateral side gets fixed, stable to varus, still opens on valgus. What do we do now? We don't go around and fix the medial side, we reassess it. And when we reassess it, it starts to sublux. Now it's nearly about to go out. And so you can't accept that. And so now you go around the medial side and you fix the medial side. And so this has now been fixed with an internal brace concept of the medial collateral ligament with an anchor in the anterior inferior medial epicondyle and in your sublime tubercle. Very difficult to do the MCL to get that right, that isometric point. You might have noticed the internal brace concept. What you might not have noticed is those drill holes in the back of the olecranon coming to our final point and moving us a little bit further in the elbow world, because what I've also done there is not only do the anterior band, but I've also reconstructed the posterior band of the MCL. So in summary, the terrible triad: elbow dislocation, coronoid fracture, radial head, and within that group there are triads and triads. Believe in static incongruity and dynamic congruity. You can treat them non-operatively. Most times you'll fix them and fix them well so that you can get them moving. Thank you.
Thank you, Mr. Van Rensburg. Couple of questions. First one is, in a simple dislocation, and EUA shows instability less than 30 degrees. How do you treat them?
So if I do an EUA and they're not stable within 30 degrees of extension, part of my EUA is my varus and valgus stress, and so I see where the major injury is. If there's a significant lateral injury, I'll go around and fix the lateral side first. It's easier, there's no tigers around there. After I've done the lateral side, I'll reassess the elbow to see whether I need to go around the medial side. If they're still not stable, I go around the medial side, and they don't leave theaters until they are stable to within 30 degrees of extension.
Okay, and what position is the arm when you fix it at the radial head?
For me, I do my radial heads through Boyd's approach. Go to cambridgeorthopaedics.com, follow the links to the YouTube channel, lateral approaches.
And final question, how do you use IJS? And
I've seen it used. I know you can use it. But in fact, if you've got a good radial head replacement and you know how to repair the soft tissues, in 15 years, I've not had to put an X-fix on an elbow if it was done as a primary procedure. So you don't need to use the IJS. You use the IJS if you don't know how to do that soft tissue ligament reconstruction.
Okay, thank you.
Thank you very much. So moving on, last but not least, we are honoured to have Miss Deborah Higgs talking to us all today about elbow arthritis, diagnosis and management. She is a consultant shoulder and elbow surgeon at the Royal National Orthopaedic Hospital, Stanmore, and is currently the clinical director for specialist surgeries. She has a specialist interest in complex surgery of the elbow and shoulder, with a tertiary referral practice that reflects this, and lectures internationally on this. She's a reviewer for the Bone and Joint and Shoulder and Elbow Journal, and is a current member of the British Elbow and Shoulder Society Education Committee, as well as a surgical tutor for the Stanmore training programme. We thank her for giving up her evening to teach us all today, and therefore, without further delay, I'll hand you over to Ms. Higgs.
Hi, thank you very much for inviting me. Right, let's hope we can share the screen. Okay, hope everyone can see that. Yeah. So I'd like to thank everybody for inviting me this evening to talk about elbow arthritis. My name's Deborah Higgs, and I work at Stanmore. This is our brand spanking new building. This is the team. In the talk, I'm hoping to cover biomechanics, as I was asked to, diagnosis, management options, and complications of total elbow replacement. As has already been described by Livio, the elbow is basically a functional link between the shoulder and hand. It basically puts the hand in space for your use. It's a weight-bearing joint, and on axial loading, about 40% of weight transfer occurs through the ulnohumeral joint. The joint surface, as has already been described, is tilted anteriorly about 30 to 40 degrees, and the elbow joint itself is both a hinge and pivot joint, the pivot at the radiohumeral articulation and the hinge at ulnohumeral articulation. The elbow axis runs through centered at the trochlea and the capitellum, and the longitudinal axis of prosupination is a line which bisects the proximal radial head in its center and distally through the fovea of the ulnar styloid. Regarding elbow stability, now this is important in terms of your decision making and how you're going to treat the patient. And as in other joints, there are both static and dynamic stabilizers, which are divided into primary and secondary. And these compose the collateral ligaments and also the muscles which traverse the joint. Regarding elbow arthritis, the most common is inflammatory arthritis, particularly rheumatoid arthritis. It is also affected by osteoarthritis, both primary and post-traumatic arthritis. Regarding osteoarthritis, primary osteoarthritis of the elbow is not common. Its incidence is about 2%. It primarily affects men of sort of working age, and patients present with progressive pain, particularly at end range, loss of terminal extension, painful locking or catching. Night pain, however, is unusual. With regards to inflammatory arthritis, as already mentioned, the most common is due to rheumatoid arthritis, although it's also linked with psoriatic arthritis. And in rheumatoid arthritis, the elbow is usually involved in about 50% of cases. However, the hand and wrist involvement often precedes the elbow, and patients present with symptoms of pain, through range, loss of motion, swelling, and instability. One of the gradings that you probably should be aware of for the exam is Larson's grading related to rheumatoid arthritis. This is a radiological grading ranging from 0 to 5, which essentially runs from a normal joint through to one that is described as being mutilated. With regards to my practice and the management of elbow arthritis, after you've obviously taken history and examined the patient, as you always would, in terms of imaging, one starts with a radiograph, AP and lateral views. The one on screen is a patient who's in their 40s, has a background history of JRA, and what isn't shown on the X-ray is that they have particularly small, short limbs. In a situation like this, I would also get a CT scan where I'm looking for bone stock, I'm looking for the dimensions of the canal. And in this particular case, on sizing, it was clear that one of the implants which would be routinely available just wasn't going to fit. And so on this occasion, I needed to go custom. And this is a custom Discovery elbow replacement, which was designed specifically for this patient. Regards treatment, obviously you've got non-operative and operative options, which you would consider like in any other joint. In terms of non-operative, particularly in the young patient who has mild to moderate symptoms, you're looking at management with non-steroidals, the judicious use of corticosteroid steroids, splints, and the very difficult conversation which goes around activity modification, particularly if they're sporty or if they're still of working age and manual workers. Regards interventional treatment, in young patients where there's a florid inflammatory picture and a synovitis, you can consider doing an arthroscopic or open synovectomy. For an open synovectomy, you can use a lateral column approach as described by Bernie Moray, or for those who are skilled arthroscopists, you can do it arthroscopically. However, if you're going to do arthroscopically, particularly if the patient has a severe restriction of movement, You have to be mindful of just how close all the neurological structures are to your port sites. And if you look at the literature, the complication rate can be as high as 5% or more in relation to neurological injury for arthroscopic synovectomies. Regarding bony procedures, particularly in the osteoarthritic elbow, you have what we call the OK procedure, or the Outerbridge Kashiwagi procedure. And essentially that's where you create a fenestration or a hole in the olecranon fossa, about 1.5 centimeters in size. And if you're going to do this open, you do it through a split in the triceps through a posterior approach. By creating the fenestration in the olecranon fossa, you can then access the anterior joint and the tip of the coronoid, removing any osteophytes, and you can even do an anterior capsulectomy through the fenestration. In terms of arthroplasty, when you think about arthroplasty, obviously total elbow replacement is what immediately springs to mind, but there are some others that you should be aware of. For your young arthritic, in a post-traumatic situation or in a florid inflammatory picture, you can consider doing an interposition arthroplasty. This is something that's described where you use a graft, which can be fascia lata, anconeus, or an Achilles tendon allograft. Essentially, you disarticulate the joint and then you suture it to the distal surface of the humerus, and then often use an external fixator post-operatively to allow early active motion. In terms of the use of interpositional arthroplasty, Bernie Moray and the Mayo Group published a paper in 2008 in the JBJS America, and there they looked at 38 surviving grafts. In those results, they described 13 patients as having good or excellent results, 14 as having fair results, and 11 patients having poor results. The conclusion they reached is that this surgery should be reserved for the young patient, that it was, in their words, a salvage procedure. And this was because patients were neither completely eliminated of pain and function was not completely restored. They also highlighted that preoperative instability was something that was a relative contraindication to doing the procedure, because in those patients, they had a particularly poor outcome. When it comes to replacement, you have what is available, which is the lateral elbow replacement, or the LRE. So this was designed by Joe Pooley and basically describes a resurfacing of the capitellum, which articulates with the resurfacing of the humeral head. And this is utilized in lateral elbow osteoarthritis in patients where the ulnar humeral joint is relatively preserved. He published a paper in 2018 where he looked at 27 patients with 30 elbows and described having a 100% survival rate of the implant. Advantages attributable to using this type of implant is that the restrictions that you place on a patient with the total elbow replacement are not the same. So basically you allow them to do far more with the elbow than you ever would do with the total elbow replacement. Then we move on to total elbow replacement. So these can be described as being unlinked, linked, or convertible, which is what this image shows of the latitude. This table shows the advantages and disadvantages between linked and unlinked. When you're looking at unlinked, one of the examples would be the Pseudostratified. In order to implant this, you absolutely have to have competent collateral ligaments. The idea is that basically you have preserving of stock because the stems tend to be quite much shorter, and that because there's less stress on the components, because the components are not linked, you get reduced polyethylene wear. However, there's always a downside, and instability is the most common complication. This is borne out in a long-term paper, which was published in JBJS, where they looked at the Kaplan-Meier and calculated a 69% survival rate at 10 years. In terms of the linked implants, which is what I tend to use. I primarily use the Discovery, but I also use the Coronoid and XL, particularly in revision situations. This describes a sloppy hinge, which allows for some varus valgus motion of about 6 to 8 degrees. However, there are notable increased stresses at the bone cement interface, which can lead to component loosening. We then move on to the convertible, the Tournier latitude. The advantages of this is that whilst you can use it as unlinked, you also have the ability to modify the implant intraoperatively, converting it to a linked if it is felt to be unstable on table. If you look at the NJR data in terms of what we're doing and how we're doing it in this country, so this data is taken from the most recent NJR report from 2019. And you can see that we did in this country, or at least documented in the NJR, 363 primary total elbow replacements, about 50% of which were for inflammatory arthritis. You compare that to the number of hip replacements done, which was 280,000 over a 3-year period between 2017 and 2019. If you look at what implants we're using, as you can see, primarily using the linked implants, the Coronoid, the Discovery, the Latitude, and the NXL, which is the newer implant to the market. If you look at the Latitude, that's languishing at around 16. And regarding the LRE that we previously spoke about, again, you can see the numbers are very small, with only 12 recorded in the NJR in 2020. In terms of contraindications to total elbow arthroplasty, again, similar to arthroplasty elsewhere in the body, active infection, a complete no-no, and so therefore one option to consider is arthrodesis, although there is a failure rate when there is a history of infection. In terms of position, if you're going to do it unilaterally, you fix the elbow at 90 degrees of flexion. However, if it's going to be bilateral, you put one in relative extension to reach the perineum at about 115 degrees. About 65 degrees, and then if the other contralateral side in relative flexion of 65 degrees so that you can reach head and mouth. Another contraindication is a Charcot joint. So these sequential images show a patient who presented with an elbow looking like this with a known cervical syrinx. They were operated on, not by me, where they had a total elbow replacement, and then quite quickly post-operatively developed a periprosthetic fracture, the tip of the humeral component, which was fixed. And then on the right-hand image, you can see that they subsequently developed a periprosthetic fracture proximal to the plate. Complications. Total elbow replacements are absolutely not without their complications. They include aseptic loosening, infection, periprosthetic fracture, instability, and bushing wear, where when you are concerned, you look at the AP X-rays, and where you've got a varus valgus angle of greater than 10 degrees, this should raise concerns about bushing wear. Regarding wound healing, this is always a concern. It's quite a superficial joint, not much in the way of soft tissue coverage, and particularly in your rheumatoid on long-term steroids or taking anti-TNF, then you need to be extremely, extremely careful. There's also the risk of ulnar neuropathy. Regarding the literature and outcomes, so this is a paper from the Mayo Group looking at their elbow replacements over 3 decades. And as you can see, they describe survivorship of 92% at 10 years and 68% at 20 years. Regarding a systematic review of the literature, so this was published in the Archives of Orthopaedic and Trauma Surgery, looking at over 9,000 elbows and 1,200 revisions. And again, you can see aseptic loosening in nearly 40% of cases, 20% of deep infections, 12% of periprosthetic fractures. And again, if you look to see what happens in the UK, if you look at the NJR data, you can see that indications for revision include a significant portion of those with infection and also aseptic loosening. In summary, in terms of what's going to determine your outcome, one, it's related to the etiology. Is this an inflammatory picture or is this an osteoarthritic picture? Patient factors, their age, what they're expecting to do with the elbow, and what their lifestyle is. And then obviously surgeon factors in terms of determining what you're going to use and how you're going to use it. But beware, once you start, it can end up in a situation like this, where you end up with a patient with multiple revisions. And yes, that really is an ulnar component in the radius, which is fractured, in which case you can end up with this, almost a bionic arm. Thank you.
Thank you very much, Ms. Higgs. Just one question. I think Di Mascio has kindly answered one on your behalf. But the one question remaining is, would you consider radial head resection with arthrolysis in isolated lateral elbow arthritis?
I rarely do, if I'm honest. I think what I would prefer to do is a lateral elbow replacement. I think that the results are good, and if you pick your patient well, they'll have a really good outcome, and it's easily convertible to a total elbow replacement. So that's what I would do in my practice.
That's great. Thank you very much. Any other questions for anyone else in the audience? Otherwise, we'll bring this session to a close. Well, on behalf of sorry.
No, nothing. Well done. Thank you very much, guys.
Brilliant. Well, I think on behalf of the BOTA committee, Romina, Kriti and George, myself, and also all the attendees, a massive thank you for the 3 speakers who have spent their Sunday evening giving up their time to provide and share their experience and their really valuable presentations. So a huge thank you for that. It's one of the best attended sessions to date with more than 100 participants. So it just demonstrates the quality of the speakers that we've had this weekend. So a massive thank you.
Thank you very much for inviting us. Really enjoyed it.
And for those of you who want to watch things back, the videos will be up on our YouTube channel and on our BOTA website, so you can watch them back and finish your notes, etc. Great, thanks.
Cheers, guys. Have a good evening.
And finally, just a few little slides just at the end. There's an opportunity really to advertise the release of our fellowship grants, which are currently now live. You can follow the link on our website. I'll post it in the chat shortly. This year, we're actually giving away £14,000 worth of cash, and that's over 9 separate grants. And all the conditions for applications can be found on our website. We thoroughly recommend and encourage everyone to apply this year because there's a very good chance of people receiving these awards. The deadline is 31st of May this year. And those that are successful on application via an electronic form that will be found on the website, you'll be invited for interview on the 5th of July. The conditions of application include you have to be a BOA and a BOTA member, be a holder of a NTN, and must be available for the pre-congress interview on that date. And those are just the awards that we're going to be giving this year, and the number of awards for each denomination. So we would recommend you apply for those, and I'll post the link on the chat now.